Welcome everyone. My name is Brúnó Balázs and my PhD title is Novel Methods to Optimize Cardiac Catheterization. I am a PhD student at Semmelweis University Heart and Vascular Center and my vision is to enhance the safety of the cardiac catheterization laboratory team by reducing occupational hazards. Therefore, my mission is to provide forward-looking and novel scientific results in occupational radiation safety. Currently, I have two projects underway. The first one is investigating the risk of radiation exposure for different personnel during fluoroscopy-guided cardiovascular procedures, and I would like to conduct a systematic review and meta-analysis to explore the topic. The number of percutaneous procedures to treat cardiovascular diseases has rapidly extended in the last 3 decades. And those performing these type of procedures has significantly increased risk for developing several heart problems compared to unexposed subjects. The primary risk is most related to radiation and radiation-induced illnesses. The association with cataracts is well documented, and there are growing concerns for radiation-induced malignancies by reported cases of predominantly left-sided brain cancer in interventionists and the signal of increased breast and skin cancer prevalence during cath lab workers. As you can see on the figure, the approximate position of the key staff members are fixed. At the head of the patient, the anesthesiologist and the transesophageal echocardiography operators standing, and on the right side of the patient there is the primary operator, and next to them the secondary operator or the scrub nurse. The position of the three members around the X-ray table can often determine the exposure risk. So with this project, our aim is to examine the radiation hazards between different personnel in the catheterization laboratory and identify occupation in need a higher level of radiation protection. The clinical question is, which personnel have the highest radiation risk during fluoroscopy-guided procedures? For the question framing, we use the PICO framework. The population is the personnel in the catheterization laboratory. The exposure group is the ancillary staff, and the comparator is the primary catheter operator, and the outcome is radiation received by the personnel measured with dosimeters. Our hypothesis is that the ancillary staff members standing at the head have higher radiation exposure than the primary operator, and those standing in the secondary position have lower radiation exposure. The clinical implication would be to apply a greater range of radioprotective devices for non-operator personnel than the current practice. On the 20th of November, I performed a systematic search in 5 different databases with the presented search key, and after that I got more than 6,000 results, and after automatic and manual duplicate removal, we started the title abstract selection with a little more than 2,800 articles. I performed the title abstract selection, and after the second reviewer finishes the process, we will evaluate the inter-rater variability by calculating Cohen's kappa, and as my results, I expect to start the title abstract selection with approximately 800 full text after the conflict meeting. So to assess the progress on my first project, we are basically just a few steps away to start the full text selection. The second project is evaluating various types of radio equipment in the catheterization laboratory, or the Everett Phantom study. We can say that interventional imaging and treatments have reached a significant success and clear benefits to our patients, but Safety measures for personnel in the catheterization laboratory have lagged the pace. Even though the aforementioned risks are known, worker safety in the fluoroscopy laboratory often remains inadequate. We have to shift the paradigm and put focus on healthcare personnel protection. It is important to emphasize the importance of investment and provide clinical data that will arise attention for all stakeholders. Every personnel stepping into the catheterization laboratory is legally obliged to wear personal protection, meaning thyroid collar and lead protective apron, but the uncovered body parts are not negligible. A review states that physician head during cardiac interventions receives 10 to 20 times higher radiation dose than body parts covered by the protective apron. Environmental radiation protection devices can further reduce the radiation exposure for different body sites without an orthopedic burden. So with this study, our aim to evaluate the efficacy of various forms and levels of radioprotective solution for different personnel in the cardiac catheterization laboratory. As you can see on the figures, there are a variety of environmental radiation protection devices available, including ceiling-mounted shields, movable lower body shields, and patient-applied radioprotective drapes. Our clinical question is, how much can the addition of these different radioprotective devices reduce the occupational radiation exposure for the personnel in the catheterization laboratory? And we will build an operation model in the catheterization laboratory with mannequins in typical occupational positions and with an anthropomorphic imaging phantom used as a mock patient or scatter body, and we will do dosimetric measurements on different personal body sites, evaluating the efficacy of different levels of environmental radioprotective device setups. As interventions arm, the control will be the basic personal protection, and the observed outcome is the personal dose equivalent rate. Our hypothesis is that various additional radioprotective devices have different capabilities to reduce the personal exposure. The research implication would be a greater level of radiation protection allows more procedures per year. As a summary, we are conducting a meta-analysis that will assess the risk of radiation for different personnel, and our second project will provide clarification to efficient level of radio protection for them. I would like to close my presentation with Marie Curie words. Nothing in life is to be feared, it is only to be understood. Thank you very much for your attention.
Thank you very much. It was a nice presentation. Just for the note, I'm an anesthetist, and I worked in labs as well. I'm just wondering if these articles report the time frame, how much time the anesthetist spent in the room, because I was never staying all the time along inside the room. So the easiest way to protect myself to leave the room.
Yes, of course. That's the most effective way for radiation protection. In some key articles and some articles that I found, somewhere they report if the anesthesiologist left the room or not, and in some cases there is no report about this matter.
I'm just wondering about this because we have a perfect invasive monitorization of the patient, and I can see everything outside of the room on the screen.
Yes. Thank you very much.
András, I was your head of department and you left the patient on the table. That's very bad practice. Don't listen to him.
Excellent presentation. Thank you. I'm really looking forward to the outcomes and the results of the study, especially the second one. As I know, under the lead, there is an annual measure and the annual level of effective dose. It's about 20 millisievert. And is there any difference between the different body parts which is not covered with lead or any protection?
Thank you very much for your question. And yes, there is. So as you said, the 7 millisievert annually is the limit below the apron, and there are recommendation and government regulation for the eye level, for the radiation dose of the eye lenses, which is 150 millisievert per year.
Thank you very much. And I have another one, if I may. Do you know any occasion when someone exceeded the limit? What are the consequences?
They have to stop working in the catheterization laboratory for that year.
Thank you very much.
Congratulations, very nice presentation. So my question would be, what is the practice in your clinic? Everybody has the same level of protection, or is there a difference between the staff members?
Thank you very much for your question. Very interesting because we are a national level center. For the primary operator position, ceiling suspended shields, movable lower body shields, lower body curtain on the table is used. There are also a nesting system in the hemodynamic laboratory. But other than that, for the ancillary staff standing at the head position, during my experience, there were no additional environmental protection for anesthesiologists or interventional imaging performer.
Thank you.
Beside the environmental protection, there are any other radiation reduction methods?
Thank you very much. That's a very interesting question. And yes, there are many, in fact, mostly related to operating technique, avoiding the use of high frame rate fluoroscopy, reducing the time of fluoroscopy, minimizing the time of cineangiography, setting the operation table to an optimal position closer to the flat panel detector, using extension tubes to standing away from the table during cineangiography and so on. So there are more advanced practices. That's for the future.